Hey, it's Medicosis Perfectionalis, where medicine makes perfect sense, and today we'll talk about systemic lupus erythematosis, or SLE. To get the maximum benefit out of this video, please watch my videos in my rheumatology playlist first. If someone said to me, hey Medicosis, we have a young buck graduating medical school or nursing school, and we want you to ask that person just one question to make sure that they know internal medicine. Just one question? Yep, the question is gonna be about lupus. Because if you know lupus, you know medicine. It's as simple as that. If you don't know lupus, it's never too late to drive for Uber. Here's a story. Meet Adam. Adam is a lupus patient. Adam decided, you know what? It's time for vacation. I'm going to the beach. And he forgot to take his lupus medications with him. He also didn't apply enough sunscreen. Do you know what happened to Adam? Sad drum roll, please. The answer is Adam developed acute kidney failure, lupus nephritis. Because what Adam did not understand is that UV light can trigger a lupus flare. He was not taking his medications, he did not apply sunscreen, the ultraviolet light destroyed him. So, if you are a lupus patient, you may forget your wallet, you may forget your phone, but never forget your sunscreen and your lupus medicine. How can we define lupus? Lupus is a weird disease that can affect any organ. Any organ in your body can be annihilated by this evil disease. It's an autoimmune, systemic, every system, symmetrical. Symmetrical only applies if you're talking about the lupus arthritis, joint problems, chronic inflammation, multi-system disease that can involve, ready? Your skin, kidneys, joints, serosal membranes. What are the serosal membranes? The famous 3 Ps, pleura, peritoneum, and pericardium. Blood cells, which ones? All of them, red blood cells, white blood cells, and platelets. Nervous system, lupus can literally drive me insane. It can lead to psychosis. Lupus is an autoimmune, therefore it's more common in females than males, especially females of childbearing age. So just because a lady has psychosis doesn't necessarily mean that it's schizophrenia, schizophreniform, or brave psychotic disorder. It could simply be lupus. The chance of a psychiatrist diagnosing this is slim to none. Lupus epidemiology, more common in females than males, especially childbearing age. It's more common in blacks and Asians than Caucasians. But anyone can get lupus. Are there some genetic factors that make you more likely to develop lupus? Yes, there are. HLA-A1, HLA-DR3, and complement 2 C2 protein deficiency. What kind of antibodies could be seen in cases of lupus? Lots of antibodies, including anti-nuclear antibodies, anti-insulin antibodies, anti-SSA, ARO, or BLA, which are Sjogren syndrome antibodies. You can see them in Sjogren, you can see them in lupus as well. Anti-thyroglobulin antibodies, anti-ribonucleoprotein, or ribonucleopeptide, or RNP, anti-double-stranded DNA, anti-Smith antibodies. These last two are very specific. But ANA is not specific. Just because you have a positive ANA doesn't necessarily mean that you have lupus. In fact, 1 out of every 9 females in the general population have positive ANA and they don't have any disease. It's not a specific test. There are some environmental triggers for lupus. Ultraviolet rays can trigger a lupus flare. Infectious agents such as Epstein-Barr virus or ABV, hormones such as estrogen, and this explains why lupus is more common in females than males, especially females of childbearing age. Some medications can cause lupus, and we call this drug-induced lupus. These medications are many, including hydralazine, procainamide, isoniazid. Hydralazine is a medication for blood pressure. Procainamide is a medication for arrhythmia. Isoniazid is a medication for tuberculosis. There is a topic in medicine known as hypersensitivity reactions, and you have 4 types: type 1, type 2, type 3, and guess what? Type 4. Type 1 is the fastest, within minutes. Type 4 is the slowest, 3 days, 2 to 3 days. That's a lot. In between, you have type 2 and type 3. What kind of hypersensitivity is lupus? Lupus could be anything, but it's most likely to be type 2 or type 3. What's the problem in type 2 or type 3? Basically, you have an antigen antibody attached to each other, okay? That's why you call it antigen antibody complex. But the difference is, in type 2, the antigen-antibody complex is on the cell surface. In type 3, the antigen-antibody complex is floating freely in the serum. And then this lovely married couple eventually is going to reach your kidney, destroying your kidney. We call this lupus nephritis. Destroying your vessels, lupus vasculitis. Destroying your joints, lupus arthritis. Lupus could be type 3 hypersensitivity or type 2. Let's talk about type 3. Aminocomplexes. What's the antigen? DNA. What's the antibody? Antibody against the DNA. Duh. This will lead to inflammation. Where? Everywhere. Because they are floating freely in the blood, and then the blood will take them to the skin. Skin problems. Kidney disease. Joint disease. Small vessel disease. That's why lupus is a small vessel vasculitis. Never forget that. Small vessel vasculitis. Lupus could be also type 2 hypersensitivity, antigen antibody on the surface of the cell. In this case, it's a cell in your bone marrow, destroying your hematopoiesis. Red blood cells are gone, white blood cells are history, platelets are mystery. No red blood cells, anemia. No white blood cells, leukopenia. No platelets, thrombocytopenia. When you are anemic, you are tired and pale, pale and tired. Leukopenia, infections. Thrombocytopenia, bleeding. And don't forget, petechiae, purpura, ecchymosis, mucosal bleeding, etc., etc. Let's talk about vasculitis briefly. Vasculitides are divided into, I love this word, vasculitides, my favorite word in the English language. We have small vessel vasculitis, medium vessel vasculitis, and large vessel vasculitis. Large vessels are the arteries. Medium vessels are the muscular arteries. Small vessel is the arterioles, venules, and capillaries. Where is lupus? Lupus is here, baby. It's a small vessel vasculitis. And when lupus causes vasculitis, it causes inflammation and necrosis. What type of necrosis? Fibrinoid necrosis. The same necrosis that happened to blood vessels in cases of rheumatoid arthritis, if you have watched my previous videos. When you have an immunological disease destroying your vessels, it's a fibrinoid necrosis most of the time. Signs and symptoms of lupus. Everything that can go wrong will. It's like a country song. Constitutional symptoms. What does that mean? Symptoms that are not organ specific. So you have fatigue, fever, weight loss, and joint problems. Remember, lupus is an inflammatory disease. So you get the cardinal signs of inflammation: redness, hotness, swelling, pain, loss of function. Rubor, calor, tumor, dolor, functulaceae. My Latin is not up to par. Hematological findings, by the way, these are the most common findings in lupus patients. Almost all lupus patients will have one of these: fatigue and pallor, infections, bleeding. Lymphatic findings, generalized painful lymphadenopathy. And this is different from cancer because cancer is a painless lymphadenopathy. Also, don't forget one of your lymphatic organs is the spleen. You get splenomegaly. Joint problems, it's an inflammatory arthritis. Okay, so redness, hotness, swelling, pain, loss of function. Symmetrical, right and left. Non-erosive, non-deforming. This is so important because this is different from rheumatoid arthritis. Rheumatoid was erosive and deforming, but lupus, most of the time, is non-erosive, non-deforming. That's a big difference. So, in lupus, you are less likely to see the Z thumb deformity, the swan neck deformity, the boutonniere's deformity, the severe ulnar deviation, etc. Which joints are more likely to be involved? PIPs and MCPs, very similar to rheumatoid. Since lupus and rheumatoid are both inflammatory freaking arthritides, they will have cardinal signs of inflammation. Both of them will have constitutional symptoms, joint pain that improves with use. So the pain is worse in the morning. As you move, as the day progresses, you're washing out your inflammatory debris, and then the pain is gonna improve. So the pain is worse in the morning. Symmetrical joint involvement, because these autoantibodies are evil and they don't care about right arm or left arm. They destroy everything. Elevation of ESR and CRP. It's an inflammatory arthritis, therefore affects small joints, more common in females. It's a chronic disease with acute flares. Remember the story of Adam who went to the beach. If you aspire a joint, you'll find inflammatory arthritis. White blood cells will be greater than 2,000 but less than 70,000 or so, and predominantly neutrophils during the acute flare. Morning stiffness that lasts more than 30 minutes or more than 1 hour, and you might see synovitis. But in lupus, non-erosive arthritis, non-deforming arthritis. A tale of two countries across the pond. In the US, lupus skin manifestations are worse on the left side of the face and the left side of the body. In the UK, they are more common on the right side of the face and the body. Have you ever wondered why? It's because of driving. In the United States, the driver is sitting on the left side, and therefore his left side of the face and his left side of the body are exposed to sunlight, and ultraviolet light will cause flares. But in the UK, Japan, etc., the driver is sitting on the right side. Skin findings in lupus: the famous malar rash, the butterfly rash on the cheeks and the nasal bridge, but it spares the nasolabial fold. Very important to know this. And as you know, ultraviolet rays will exacerbate the rash and they cause flares. If you biopsy the skin using immunofluorescence techniques, you will see the nasty autoantibodies at the dermoepidermal junction of the skin. Remember, it's a hypersensitivity reaction. These autoantibodies are nasty and they are everywhere. Renal manifestations in lupus occur in about 50 to 70% of patients. Hey medicosis, does lupus cause nephritic syndrome or nephrotic syndrome? It can cause both, nephritic and nephrotic. Nephritic, diffuse proliferative glomerulonephritis, it's common and severe. Nephrotic is the membranous. Chronic kidney failure is a very common cause of death in lupus patients. Here is nephrotic syndrome and nephritic syndrome. Let's review nephrotic syndrome. If you remember, nephrotic syndrome had high protein in myuria, low protein in myemia, edema, and hyperlipidemia. Nephritic syndrome, you have 7 things. Number 1, it has itis, right? Itic, itis, which means inflammation. Oh, so there is inflammation, that's why I have blood in the urine. Hematuria. Your kidney is toast, oliguria, and elevated BUN and creatinine. When the kidney is toast, your blood pressure can increase. Yup, renal hypertension. When your urine volume is low, fluid is going to accumulate all over your body. You will have extracellular fluid volume overload with jugular venous distension and edema. There is some mild proteinuria. It's not as severe as nephrotic syndrome. So if you have lupus, you can have blood in the urine, which can make your anemia worse, by the way. Kidney disease in lupus, we have 6 classes. So if you have lupus, you can get minimal mesangial lupus nephritis. You can get mesangial proliferative lupus nephritis. You can get focal lupus nephritis, diffuse lupus nephritis, which is the most common and the most severe. You can get membranous. You can get advanced sclerosing lupus nephritis. When everything hits the fan, you will need dialysis. It's an evil disease. Let's talk about the heart. The heart can get fibrinous pericarditis. Maybe pericarditis with effusion or without effusion. And this is an example of serositis because the pericardium is one of the serosal membranes lined by mesothelial cells, if you remember your anatomy. The pericardium is the outer layer of the heart. The inner layer of the heart can also be affected, and this is Liebman-Sachs endocarditis. Sterile vegetation. What does sterile mean? They don't have bacteria. Unlike bacterial endocarditis, where they do have bacteria. These vegetations are over the mitral valve usually, causing deformity of the valve and mitral valve regurgitation, and you can hear the murmur of mitral regurgitation, which is a pan-systolic murmur best heard over the apex of the heart, which is in the left fifth intercostal space mid-clavicular line, just below the patient's left nipple. Some words of wisdom. Any female at childbearing age with unexplained serositis, could be pleurisy, pericarditis, or peritonitis, has lupus until proven otherwise. This is so important. Lung problems against serositis. So here the serosal surface is the pleura. Pleuritic chest pain. What does that mean? It hurts when I breathe, but when I'm not breathing, it doesn't hurt. It sounds like this. It hurts. And then I stop breathing, I feel nothing. And then I breathe again. It hurts. Why? Because every time I'm breathing in or out, the pleura is moving and it's inflamed, causing the chest pain. When you stop breathing, this pain will stop, unlike the pain of myocardial infarction or angina. Whether you're breathing or not, angina doesn't care. Because angina is a stupid clot in your coronary, it is not related to the pleura at all. See, medicine makes so much sense once you understand what the flip you're talking about. Lupus can also lead to an interstitial pulmonary fibrosis, which is a restrictive lung disease, which means my lungs are restricted from filling. You'll have decreased all of the lung volumes and capacities. How about the total lung capacity? Decrease. Tidal volume, decreased. Expiratory reserve volume, decreased. Residual volume, also decreased. The only thing that increases is the ratio, which is the FEV1 to FVC ratio. The ratio could be increased or it could be normal in restrictive lung disease. To learn more, check out my Medicosis Pulmonology playlist on YouTube. Neurological symptoms: headache, psychosis. Yes, lupus can make me psychotic. Seizures and stroke. Why stroke? Let's think about it. There is something called antiphospholipid antibody syndrome, and they are one of the causes of hypercoagulability. If you remember, hypercoagulability means clots. If these clots happen in your vertebral circulation or the internal carotid circulation, you can get a stroke. Is it an ischemic stroke or a hemorrhagic stroke? Usually ischemic stroke. Lupus and pregnancy. All right, here is the newborn. The newborn is going to suffer a lot. It can lead to third-degree AV block, which is complete heart block. Why did this happen? Do you remember the anti-SSA row? Oh yeah, Sjogren syndrome A antibodies. Yeah, they are IgG. What does that mean? IgG antibodies are small and they can cross the placenta. If they can cross the placenta, they will go from mommy's blood to the baby's blood, attack the baby's heart, especially the cardiac conductive system, SA node, and more importantly, the AV node, causing complete heart block, where the atria and the ventricles are contracting independent of each other. The antiphospholipid antibody syndrome has hypercoagulability, vessel thrombosis, and can cause miscarriages. Drug-induced lupus, fever, arthralgia, sinusitis. What kind of drugs are you talking about? Hydralazine, procainamide, isoniazid, and others. If you have drug-induced lupus, you will have a positive antihistone antibody test. These are autoantibodies attacking your histone proteins. What the flip is that? The histone proteins are proteins, those blue ones, around which your DNA is gonna wrap itself until it becomes a condensed chromatin. So the histone is not your native DNA. The histone is a protein block around which the DNA is gonna wind or wrap. So what's the difference between lupus and drug-induced lupus? Okay, antihistone antibodies are only found in lupus. Antibodies against the native DNA, not the histone, the actual freaking DNA, which was brown colored in the previous slide. Found in lupus, not in drug-induced lupus. How about low complement levels in the blood? Lupus, not in drug-induced lupus. CNS involvement, the headache, the psychosis, etc. Lupus, less likely in drug-induced. It can happen, but it's less likely. Also, symptoms disappear when you discontinue the drug is characteristic of drug-induced lupus, but not lupus. But hey, Medicosis, I'm not taking any drugs. Do you think I have drug-induced lupus? Shut up. Most commons in lupus. The most common initial complaint is joint pain. The most common constitutional symptom is fatigue. The most common joint involved are the PIPs and the MCPs, small joints. The most commonly involved system is hematological. So you have anemia, leukopenia, thrombocytopenia. The most common visceral organ involved is the kidney. The most common cardiac finding is fibrinous pericarditis. The most common respiratory symptom is pleuritic chest pain. Let's try to diagnose lupus. First, you need history and physical exam, and then let's go to the lab. All of these autoantibodies. How about anti-nuclear? They are sensitive. You can use them to rule out. If your ANA test is negative, it's unlikely that you have lupus. It's not impossible, but it's very unlikely. What if my ANA is positive? Does that prove that I have lupus? Shut up. It does not. It's not very specific. However, anti-double-stranded DNA and anti-Smith antibody are very specific. If they are positive, you almost always have lupus, but they are not very sensitive. They cannot rule out. They can rule in, they cannot rule out. The exact opposite of the ANA. This is an old test known as the Lupus Erythematosis cell, or LE cell. Basically, that was a neutrophil that contained phagocytosed altered DNA. This is historical. No one uses this today because we have better tests including anti-double-stranded DNA, anti-Smith antibodies, etc. If you measure my complement in my blood, it's probably going to be low if I have lupus, specifically C3 and C4 complement proteins. Antigen-antibody complex, this is the immune complexes. They float in the blood, vasculitis. They go to the joints, arthritis. They go to the kidney, nephritis. For this to happen, you need some complement. That's why in lupus, your complement has been consumed. So when you measure it in the serum, it is low. Causes of hypocomplementemia are many. Could be genetic, could be underproduction or overconsumption. In lupus, it is overconsumption. C2 and C4 are low in these diseases. C3 and C4 are low if you are over-consuming your complement. Why did we call it complement? Because it complements the function of the antibody. Next, we have the immunofluorescence test or IF test. Basically, we're looking for those doozy autoantibodies in the skin and in the kidney. In the skin, you'll find them at the basement membrane. In the kidney, you will find them in many places depending on which class of lupus nephritis does the patient have. Anti-double-stranded DNA, specific IgG subtype. How do you detect it? ELISA or immunofluorescence, very specific for lupus, not sensitive for lupus. It correlates with disease activity. If you have anti-double-stranded DNA, you might suffer from glomerulonephritis. The greater the titer, the greater the risk. Do I find this in drug-induced lupus? No, you do not. Instead, you'll find antihistone antibodies. The pathogenesis of the anti-double-stranded DNA was discussed before in my video titled Anti-Double-Stranded DNA Antibodies. Do they correlate with disease activity? Absolutely. Lupus activity, lupus nephritis, lupus vasculitis, you name it. If you have an acute flare, they will rise a lot. What if I have lupus? I went to the doctor gave me medications, and now the anti-double-strand DNA are decreasing. It means you are responding to therapy. If you have anti-double-stranded, you might respond to a drug known as belimumab. Believe it or not, if you're taking TNF inhibitors such as adalimumab, etanercept, infliximab, you might have positive anti-double-stranded DNA. Anti-double-stranded DNA correlates with the disease activity in many but not all patients. How do I know? Alright, the patients are divided into two groups, those who correlate and those who do not correlate. So you have to follow up with the patient. Every time there is a flare, measure the anti-double-stranded DNA. Does it correlate with the flare? Then the patient is in this group. If the antibodies do not correlate with the flare, then the patient is in this group. Pause and review. Anti-Smith, antibodies against nuclear protein known as Smith antigen. 25% only of patients have this anti-Smith, that's why it's not sensitive. But once you have it, it is very specific. Does it correlate? It does not correlate with disease activity. Next, anti-U1-RNP, ribonucleoprotein. You can find this in mixed connective tissue disease. You can also find it in lupus patients. Anti-ribosomal P proteins can also be seen in cases of lupus. Anti-SSA and anti-SSB can be seen in lupus and Sjogren. And don't forget, it was the ugly anti-Rho that crossed the placenta and damaged the baby's heart. Complete heart block or third-degree heart block. So if I have lupus, I am likely to have anti-double-stranded DNA, anti-Smith antibodies, anti-U1-RNP, and anti-ribosomal P protein antibody, among others. Specific, specific, non-specific, specific. Rho, Bila, Sjogren, lupus, both can cross the placenta, both can lead to neonatal lupus and congenital heart block. Anti-SSA means different thing in different diseases. Let's say I have Sjogren. This means that I'm more likely to get non-Hodgkin's lymphoma. But let's say I have lupus. It means I am more likely to get lupus nephritis. Question. Let's say you have a patient and the patient has rheumatoid arthritis. This patient presents with positive anti-double-strand DNA. What does that mean? It means one of two things. Number one, the patient has lupus. What the flip is that? Lupus is lupus plus rheumatoid. Oh, that's a fancy name. Yes, indeed. It's lupus. Or it could be you're treating the rheumatoid using one of the TNF inhibitors, which will cause an anti-double-stranded DNA antibody. The diagnostic criteria of lupus from the American College of Rheumatology are here. Basically, to diagnose the patient of lupus, you need 4 total criteria. So some from here, some from here. If they add up to 4, the patient has lupus. But you need at least 1 from this column and 1 from this column, and then the total has to be 4 or more. Let's manage lupus. Do you remember these medications that we have mentioned in rheumatoid arthritis? Yep, exact same medications. All right, you're going outside, don't forget your sunblock. Never ever forget that. Do not repeat Adam's mistake. If you have mild skin lesions, local steroid. Mild arthritis, non-steroidals. Skin lesions or arthritis, hydroxychloroquine. The dose is 200 to 400 milligrams per day. HCQ is awesome for lupus. It decreases acute flares, it increases survival, but unfortunately it has many side effects including neuropathy, myopathy, retinopathy. It's very bad for the retina. If you're taking HCQ, make sure to follow up with a freaking ophthalmologist every 6 months or every year or whatever. Let's say I have immune hemolytic anemia or immune thrombocytopenia, myocarditis, alveolar hemorrhage, CNS symptoms, glomerulonephritis, etc. You need glucocorticoids. Other immunosuppressants include cyclophosphamide, mycophenolate mofetil, azathioprine, rituximab. If it ends in mab, it's a monoclonal antibody. Monoclonal antibody against what? Against CD20. What do you mean? I mean the B lymphocytes. Why B lymphocytes? Because the B lymphocytes produce antibodies. And we're talking here about an autoimmune disease with freaking autoantibodies. See, it makes sense. Methotrexate, tacrolimus, and belimumab, which is an anti-B cell growth factor monoclonal antibody. It destroys your B cells so that they do not become plasma cells, so that they do not secrete antibodies. Hydroxychloroquine was discussed before in my rheumatology playlist. Don't forget, you can use it to treat lupus and rheumatoid. Side effects include retinopathy, skin hyperpigmentation, neuropathy, myopathy, hemolytic anemia if you have G6PD deficiency. It may exacerbate psoriasis and it can lead to something called synchronism. You know why synchronism? Because it's quinine. Synquinine. Let's talk about methotrexate. Methotrexate inhibits dihydrofolate reductase. You will not have dihydrofolate reductase, you will not make THF, you will not make purines or pyrimidines or methionine, therefore you will not make DNA or RNA. Your lymphocytes will not divide. Your B lymphocyte will never make autoantibodies. Well done. But methotrexate has many side effects, including mucositis, rash, myelosuppression, so you get anemia, leukopenia, thrombocytopenia, you get anemia with high MCV, you get interstitial pulmonary fibrosis, and it's teratogenic and it can lead to miscarriages. So it's contraindicated in pregnancy if you have liver disease, if you have kidney disease, or if you are a raging alcoholic, because alcohol inhibits folate. Methotrexate inhibits folate. If you take two things that inhibit folate, say goodbye to your cell replication. Say goodbye to regeneration. Prognosis. The prognosis of lupus is improving over the years. I was reading an ancient pathology textbook and lupus was not even mentioned. Nowadays we know better and the 10-year survival rate is improving. Now 85% of lupus patients should expect to live 10 years or more. Common causes of death in lupus: infections and chronic renal failure. Some pearls for the pros. Before diagnosing a patient with schizophrenia, brief psychotic disorder, schizophreniform, etc., make sure to rule out medication-induced psychosis, which happens after steroid use. It happens for any drug that has anticholinergic activity, including atropine, the family of atropine, antihistamines, some freaking antiarrhythmics, etc. Or the psychosis could be from a medical condition such as lupus or acute intermittent porphyria. So when your patient has psychosis, don't just go, oh, I should just refer them to a psychiatrist and that's it, I shouldn't have to worry about. Shut up. Pearl number 2. Any lady of childbearing age with unexplained serositis has lupus until proven otherwise. Thank you so much for watching. Please subscribe, hit the bell, and click on the join button. You can support me here or here. Go to my website to download my courses. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.